Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today.
Klumpke's palsy, named after the neuroanatomist Augusta Déjerine-Klumpke, who first described it, is where there's muscle paralysis in the hand, caused by nerve damage. This causes all the fingers to stay in a flexed position, so it's also called total claw hand. Now, we have 31 pairs of spinal nerves which branch off the spinal cord. These are grouped into 8 pairs of cervical nerves, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, 5 pairs of sacral nerves, and 1 pair of coccygeal nerves. Now, some of the cervical and thoracic nerves form the brachial plexus, which is a network of nerves that controls the muscles and sensations in the shoulder, arm, and hand. In terms of anatomy, the brachial plexus is divided into 5 roots, which come from the last 4 cervical nerves, C5, C6, C7, and C8, as well as the first thoracic nerve, or T1. The 5 roots combine to form 3 trunks. C5 and C6 merge to form the superior, or upper trunk, C7 remains as the middle trunk, and C8 and T1 merge to form the inferior, or lower trunk. These trunks then form 6 divisions, which will regroup with each other to form 3 cords. These cords give off 5 terminal branches. The main 3 are the median nerve, which is made up of contributions from C5, C6, C7, C8, and T1, the radial nerve, which is also made up of contributions from C5, C6, C7, C8, and T1, and finally, the ulnar nerve, which is made up of contributions from C8, T1, and occasionally C7. Klumpke's palsy occurs when there's a stretch or tear at the C8 or T1 roots, or at the lower trunk. This happens when an abducted arm is pulled further away from the body. In infants, this could happen when the baby is pulled out of the birth canal by the arm during delivery. In adults, a trauma to the shoulder, like when someone tries to grab a tree branch while falling, can cause the nerves to be torn. This leads to dysfunction of the median and ulnar nerves since they contain fibers from these roots. Okay, so if we look at the effects of the nerve damage, in the forearm, the ulnar nerve innervates the flexor carpi ulnaris, which controls the muscles that flex the wrist. So when the ulnar nerve is damaged, it causes the wrist to stay extended. On the other hand, the median nerve innervates pronator teres and pronator quadratus, which pronate the forearm, turning the palm posteriorly. So, when the median nerve is damaged, the forearm stays supinated, meaning that the palm of the hand faces anteriorly. Now, moving on to the hand. The median nerve innervates the thenar muscles, which control the movements of the thumb, so thumb movements are limited. Similarly, the ulnar nerve supplies the hypothenar muscles, which control the little finger, the interossei muscles, which abduct and adduct the fingers, meaning to spread or bring them together. So, an injury to the ulnar nerve causes a loss of movement of the little finger, and the inability to abduct or adduct all 4 fingers. Finally, both the ulnar and median nerves innervate the lumbricals, which are 4 muscles that extend the fingers at the interphalangeal joints, and keep them flexed at the metacarpophalangeal joints. On the contrary, muscles of the forearm oppose the action of the lumbricals. These muscles include the flexor digitorum profundus, which flexes the fingers at the interphalangeal joints, and the extensor digitorum, which hyperextend them at the metacarpophalangeal joint. When the ulnar and median nerves get damaged, muscles in the forearm override the action of the lumbricals, causing the hand to look like a claw. So, with Klumpke's palsy, we end up with a person whose forearm is stuck in the supinated position with the wrist extended. The fingers are flexed at the interphalangeal joints and can't abduct or adduct. Now, both nerves also carry sensory information from specific areas of the hand to the central nervous system. Damage to the median nerves could result in numbness in the thumb, the index finger, and middle finger, as well as half of the ring finger that's on the thumb side. The other side of the ring finger and the pinky are innervated by the ulnar nerve. Finally, the first thoracic nerve root, or T1, provides sympathetic innervation for the head, neck, and eyes. When this nerve is injured, it causes Horner syndrome, which is a triad of 3 symptoms: miosis, or constricted pupil, ptosis, a droopy eyelid, and anhidrosis, the inability to sweat. Sometimes, Klumpke's palsy gets confused with another condition called thoracic outlet syndrome. Thoracic outlet syndrome is a group of symptoms caused by compression of the brachial plexus and the subclavian artery and vein as they travel through the narrow space between the collarbone and first rib, called the thoracic outlet. This compression could be caused by a cervical rib, which is a congenital anomaly where an extra rib is located above the first rib, or by a Pancoast tumor, a type of lung cancer where a tumor forms at the tip of the lung. Overuse of the shoulder and arm can cause inflammation and swelling in the area, which also narrows the thoracic outlet. Whatever the cause, compression of the inferior trunk and roots of the brachial plexus causes similar motor and sensory symptoms in the arm and hands as Klumpke's palsy. Horner syndrome can be present if T1 is affected. In addition, compression of the subclavian artery decreases blood supply to the arm and hand muscles, causing pain and atrophy. Compression of the subclavian vein decreases blood drainage from the arm and hand, leading to edema. The diagnosis of Klumpke's palsy and thoracic outlet syndrome is based on physical examination to evaluate hand and forearm weakness. Advanced diagnostic techniques like electromyogram and nerve conduction studies may be used to further investigate if the motor symptoms are due to damaged nerves. If thoracic outlet syndrome is suspected, a chest X-ray or MRI could be ordered to identify the cause of the compression. Treatment of Klumpke's palsy largely focuses on physical therapy, which involves exercises that help recover strength and improve the range of movement. Despite this, some people will develop permanent hand weakness or paralysis. For thoracic outlet syndrome, anti-inflammatory medication can be given to decrease swelling and help manage the pain. If the compression is caused by an extra rib or a tumor, surgical removal is the best option. Alright, as a quick recap, Klumpke's palsy occurs when there's a disruption of the innervation to the muscles of the hand, caused by an injury to the nerve roots C8 or T1 or to the lower trunk of the brachial plexus. The most common symptom is weakness or paralysis in the intrinsic muscles of the hand, causing the hand to flex into a claw. Horner syndrome could occur when the T1 nerve is affected. These symptoms also occur in thoracic outlet syndrome, where the same nerves as well as the subclavian artery and vein are compressed as they travel through the narrow space between the first rib and the clavicle. These two disorders are diagnosed based on physical exam, although imaging studies might be needed for thoracic outlet syndrome. Physical therapy plays a big part in the treatment of both disorders, but surgery might be needed in certain cases of thoracic outlet syndrome.
Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine.